Hello everyone, welcome to Radiographic Procedures 1. My name is Dr. Beck. I will be your instructor for this semester. You will also see our assist, Professor Voorhees. She'll be around to help you during lab sections, especially with practicing all of those setups that you'll be responsible for throughout the semester. A little bit about me before we start. I've been teaching for about 6 years now in both the graduate level and undergraduate levels, so I've been kind of all over the place there. I've also taught here at Northeast before in the chiropractic program. My background is as a chiropractor. I did my DC and graduated from that in 2019, and then I came back for a radiology residency within the DC program for another 3 years. So that's kind of where my specialty around radiology is. I'm really comfortable with reading x-rays and CT scans and MRIs. And so throughout the course of the semester, there will be a lot of that kind of input where we'll look at what good x-rays look like and where things could improve. So to start off, we're going to start off with general anatomy, and our typical format for a lecture will be in person. But this week, given that orientation kind of falls right in that lecture span of time, we're going to do online lectures for the first 3 PowerPoints for this week so that we can stay on track. But lab this week will be in person, and we'll have a chance to kind of go through those setups that we'll learn in lecture this week. But first, we have to get some background on general anatomy, radiographic positioning terminology, and things like that. I really encourage you to get really comfortable with this lecture before moving on to the next 2, because this one has a lot of Latin terms, medical terminology that you may not be used to, and is really important because I'm going to be using that going forward. It's also really important because it's something that you'll be using every day when you start practicing as an RT. So it's something that you should get comfortable with. So first, we'll talk about some anatomical terminology. Anterior and ventral are synonyms for each other. They just mean toward the front of the body. So something to note also is that all of these terms are going to be relative to other body parts. So you could say that the nose is anterior to the back or to the spine, whereas the spine is posterior or dorsal to the nose. It's behind the nose, it's toward the back of the body. If something's medial, then it's toward the midline of the body, and lateral is away from that midline toward the outside of the body. Superior means above, inferior means below, and similar terms, proximal and distal. Proximal means toward the origin of the body part, which often is the superior part of it, but we use this usually with extremities, arms and legs. So we can say that the shoulder is proximal to the elbow because it's closer to where that arm inserts into the body. Whereas the elbow is distal to the shoulder because it's further away from where that arm inserts into the body. So we can use that for the arms or legs, proximal and distal. We also assume that when we use these terms that the patient is in an anatomical position. Anatomical position, we have an image in here somewhere, but the patient is facing forward, palms facing up, and feet facing forward. So it's important, especially when we talk about digits, when we talk about fingers and toes, because if your palms are facing upward, your pinkies are going to be medial to your thumbs. But if they're facing the wrong way, if the palms are facing down, the pinkies are going to be lateral. So we always do it in terms of anatomical position. Some more terms. Contralateral means on the opposite side of the body. Sometimes you can be standing on the contralateral side, or you might want to image the contralateral side of the patient's body. Ipsilateral means it's on the same side of the body. Deep is further from the surface. Superficial is closer to the skin surface. We can say that skin is superficial to muscle, muscle is deep to skin. And then cranial and caudal are also often used as synonyms for superior and inferior. They're just a little bit more specific. Cranial is toward the head, so it is above like superior, but it's toward the head. That's what the Latin means. And caudal is toward the tail, or toward the bottom. External and internal are kind of similar to those superficial and deep. External is on the outside of the organ or body. Internal is on the inside of the organ or body. Parietal and visceral are often used when speaking about membranes. You might hear those come up sometimes in anatomy, but parietal generally means that it's lining a body cavity versus visceral, which covers an organ. Viscera is just another name for organ. Dorsum is the top of the hand or the back of the hand, kind of like dorsal surface of the hand. Palmar surface is the palm of the hand, and plantar surface is the sole of the foot. So here's that anatomical position. We can see some of those anatomical terms, proximal being closer to where that extremity inserts into the body, distal being further away, superior being above, inferior being below, lateral away from the midline, and medial right along that midline. Anterior is toward the front of the body, and posterior is toward the back of the body, and we can see those palms are facing up, feet facing forward. We can also talk about body planes. If you're planning on going into CT and MRI, those imaging modalities focus a lot on different planes of the body, especially axial or horizontal planes, which cut the body into superior and inferior parts. It doesn't necessarily have to be halves. We can have axial planes along any part of the body. Coronal is going to go right through the head here, dividing the body into anterior and posterior halves. Again, it doesn't have to necessarily be halves. It can be a little off-center. And then we also have a sagittal plane that's going to divide the body into left and right parts. If it's a mid-sagittal plane, then it's going to divide the body into left and right halves. If it's parasagittal off to the side, then that means it's going to be divided into left and right parts, not necessarily halves. We also have different cavities of the body. This is just another way of talking about where different organs lie. First cavity we'll discuss is the thoracic cavity. So the thorax is kind of where the ribs house all these organs in the chest area. So within the thoracic cavity, we have pleural membranes that cover the lungs and the body cavity outside of the lungs themselves, the trachea or the windpipe that's going to go down and connect to the lungs via bronchi, the esophagus, which will be a little posterior to the trachea, connect to the stomach, the pericardium that will surround the heart, and the heart itself with its great vessels like the aorta and vena cava. We can also on this diagram see the abdominal and the pelvic cavities. Sometimes these are combined into abdominopelvic cavity, but this is just a way to divide it a little further. Within the abdominal cavity, we have the peritoneum, which is going to be that lining that surrounds the entirety of the organs, dividing the outside versus the inside where all the organs are. And then in that upper quadrant there on the right, we have the liver and the gallbladder that attaches to it. The pancreas sits kind of right in the middle. The spleen is over on that left side with the stomach. And then we have intestines, large and small, kidneys, and then kidneys connect to the bladder via ureters. So that's all found within the abdominal cavity. We can also use some anatomical terms here to talk about some of these structures. We can say that the heart is medial to the lungs. The lungs are lateral to the heart. The trachea is superior to the heart. And the thoracic cavity is superior to the abdominal cavity. The abdominal cavity is inferior then to the thoracic cavity. So it's just a way of talking about those in relative terms. As we move down a little further into the pelvic cavity, we have the ending of the colon or the large intestine being the rectum, the urinary bladder, which we saw part of up in that abdominal cavity, but it will be continued and kind of more protected in that pelvic cavity, and some of the reproductive organs that are internal there. So you heard me talking a little bit about the quadrants. This is generally what we use when we're talking about the abdomen, to be a little bit more specific about which area in the abdomen we're talking about. We have 4 quadrants: a right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Oftentimes you'll see them abbreviated with these abbreviations here. Importantly, these abbreviations are used, and we talk about these quadrants as if we're facing the patient. So this is their right side, as if we're looking straight at them. this is their left side. So this will be inverse when you're looking at it on yourself. Your right upper quadrant is on your true right upper side, and your right lower quadrant is on your true right lower side, etc. We can further divide those quadrants into regions if we want to be extra specific about where exactly we're talking about. So the umbilical region is right around the umbilicus, or the belly button, and above that is the epigastric region. Epi means above, gastric means stomach, so it's right above the stomach area. Below the umbilical region is the hypogastric region. Hypo means below, gastric means stomach, so it's below the region where there's the stomach. On either side of the epigastric region, we have hypochondriac regions. And you might be thinking that's a little weird. I don't know why this has anything to do with being afraid of medical conditions or the doctor. But hypo means below, remember. Chondro means cartilage. So it's actually talking about being below the cartilage of the ribs on either side. And again, this is the patient's right, patient's left. The left and right lumbar regions are referring to the area of the spine that we're at. So we're right in the lumbar region of the spine area. So this is the left and right lumbar region. And then that pelvic bone that sits there that divides the abdominal and pelvic cavities is the ilium. So this is the left and right iliac region, right where that pelvic bone is. Something to also note, we'll be using a lot of palpation when we are setting patients up for radiographic procedures. So when we're imaging patients, it's really important to know what structures are at different spinal levels. Because if I can palpate right around the inferior angle of the scapula, if you can feel the shoulder blade on the back, you can feel the little inferior or bottom area poking out sometimes. We know that that's at T7, and sometimes we'll use that as a landmark when we're setting up thoracic x-rays. So, and we can use most of these when setting up a lot of our different x-rays, especially L4 being the top of the iliac crest. So it's really important to get familiar with these. I would make sure that you know which levels are for which landmarks. You should also get very familiar with bones. I mean, this is something that you're going to be an expert in, taking imaging of any bone in the body that could be broken or otherwise diseased. There are 206 bones. A lot of them are repeats, so that's helpful. But it is a lot to learn, so you'll learn that in anatomy, and we'll get a little taste of it here too. So bones, their main job is to protect the internal organs from injury, supporting the body and all of their daily movements. They also produce red and white blood cells within the bone marrow, within the bones, especially in our long bones. And we can also divide the skeleton, all of the bones, into two categories, the axial skeleton and the appendicular skeleton. So when you think of appendicular, I want you to think of appendages. So sometimes when we hear the arms and legs referred to as appendages, that's generally what we refer to with the appendicular skeleton. So shoulders, upper limbs, lower limbs, pelvic girdle, that's all appendicular. Everything else is axial. Axial is going to be right down the center. So the skull, the neck, the thorax, the vertebral column are all going to be axial, right down the midline of the body. So here's an image that we can see. In blue is that axial skeleton. In red is that appendicular skeleton. When we talk about bone, we can also talk about some of its features. The outer layer of bone is compact bone. It's a little bit more dense, a little stronger than the spongy bone that's more internal and has a lot of trabeculae. So all these little dots within allow different nutrients to access the bone. So trabeculae, we have our red and yellow marrow depending on what type of bone we're looking at. That medullary cavity is the internal aspect of long bones, so it's kind of hollowed out there, but in reality there would be bone marrow traveling throughout that. And we also have periosteum and endosteum, which are just two membranes. So the whole bone itself is going to be covered in periosteum. Peri means surrounding, so an osteum means bone. So surrounding the bone, we have periosteum. It's going to be really highly vascularized and have a lot of blood supply and innervation, meaning a lot of nerve supply. And anytime we have something that has blood supply, nerve supply, that means that we're going to be able to feel it if something's wrong. So with periosteum, sometimes we have lifting of that periosteum in the tibia in the lower leg, and that's how you can get shin splints. So sometimes with shin splints, you'll have lifting of that periosteum, and the reason we can feel it is because it has such a nice nerve supply and blood supply. Similar to periosteum, we have endosteum. So remember, osteum means bone, endo means within. So it's actually lining that medullary cavity. It's just another membrane. We'll also talk about different parts of bones because sometimes we'll want to make sure that we're visualizing these things on imaging. Tubercles and tuberosities you'll hear about a lot. A lot of the long bones will have them. And generally these just mean that they have projections or knobs on bones. And generally those will be places where tendons or ligaments attach. So like I said, a lot of things need blood supply and nerve supply, and most bones and organs have that. If they don't, then something's wrong. There are holes in the bones called nutrient foramina that bring nutrients via blood. Foramina just means hole. So anytime you see foramen or foramina, that means hole. Foramina is just the plural form of foramen. We also have different types of bones. We've talked a little bit about long bones, and that's exactly what I mean when I say long bone. It's a long bone. So think of your femur, think of your humerus in your arm. Generally, we'll only see these in limbs. They have a longer shaft or body of the bone, and they help to provide support. So these are really important for movement and supporting our body. We have short bones, like our carpals and our tarsals. Those will be in the bones of the wrist and the ankle. Some other types of bones, we have flat bones. Think of your sternum, your breastbone, like right in the chest area, protecting your heart. Your cranium, the bones of your skull are flat bones, and your scapula, your shoulder blade in the back is also considered a flat bone. Some irregular bones, meaning that they don't have a specific shape that matches the rest of the bones. Vertebrae, your bones of your spine, are considered irregular, as well as your pelvic bones, your ilium, your ischium, and your pubis. And then sesamoid bones, sesamoid actually means that they resemble a sesame seed. So they're pretty seed-like in shape, they're small, oval-shaped, and generally these will be inside or beside tendons. Your patella is actually an example of a sesamoid bone. It hangs out in front of your knee, actually within your quadriceps tendon. We'll also see a lot of normal sesamoid bones around the thumb and around the big toe. They'll be found in places where we have a lot of motion, generally in the extremities and the small bones, to help kind of guide those tendons. Arthrology is the study of joints. Arthro means joints, ology is the study of. So we do need to know some basics about joints and what those mean. Joints are just when two bones come together. Sometimes you might hear me say that they articulate, and that just means that the bones are connected, and that's via a joint. There's three main types of joints: fibrous joints, cartilaginous joints, and synovial joints. And they're just named based off of what type of tissue is attaching the two bones together via the joint. So if you have fibers attaching two bones together, they're not going to be very movable, and that's important in bones that we don't really want that joint to move very much. So sutures in the skull that are connecting those skull bones, we don't really want those to move, therefore they're connected via that fibrous tissue. We have some that are cartilaginous, and while they're pretty non-movable, they're more movable than the fibrous joints. Some examples of those are the pubic symphysis that connects the pelvis in the front, and our growth plates as we age, also known as the epiphyseal plate or the physeal plate. We'll see these in long bones in kids, and then eventually they'll grow and the epiphyseal plate will fuse. In the case of the growth plates, it's not really a great thing that they have slight movability, because that can cause some pathologies and some weird fractures that only kids get. Lastly, we have synovial joints, and this is probably what you think of when you think of most joints. So when you move your shoulder, this is a synovial joint. Your hip joints, your knee joints, your elbows, All the things that are really highly movable are going to be synovial joints, meaning that they have a synovial membrane and synovial fluid within that kind of help pad the joint and allow it to be more freely movable. There's different spectrums of movability depending on the type of joint, but we won't get too into that. You might get a little bit more into that in anatomy. Some other types of things that you might hear of on bones, processes and projections, kind of similar to tubercles and tuberosities. This is a part of the bone that's going to project out from the main part of the bone. Other names that you might see similarly, condyles. Coracoid is a type of process that you'll see on the scapula. Crest, an epicondyle. Epi means above, so this will generally be above another condyle. But again, these are all just types of projections, bony knobs. Versus something that's kind of the opposite, depressions that are more hollow, depressed areas of the bone. The main thing that we think of when we think of this is fossa. And then the plural form of fossa is fossae, but we might see fossa in certain bones where they kind of dip in. Fissures, we can also see that as a depression, a sinus is usually a pathway for a blood vessel, but it will be kind of a dip in the bone and just be kind of chiseled around the shape of a blood vessel. And then a foramen is generally a hole, so it technically is depressed, but it's more so a hole for a blood vessel or a nerve to travel through. Fractures is something that you'll probably see a lot as a rad tech. So a fracture is just a break in the bone. There are a lot of different terms that we can use to describe fractures. If they're closed, that means that they're not going through the skin. If they're open, that means they are going through the skin, and that's concerning, obviously. When we're looking at the x-rays, displaced and non-displaced is a term that we can use to talk about the fracture fragments. So if the fracture is displaced, that means that they're not aligned. So in this case, we can look at this oblique fracture. The bone fragments on either side are aligned. It still looks like the shape of the femur with just a split in it. So these are non-displaced versus this fracture or this fracture, where we can see that there's a little bit of deviation of that bone on either side, and a little bit more so with this fracture. So the bone fragments in these cases are displaced. We can also talk about comminuted versus non-comminuted fractures. Comminuted fractures fracture into more than two pieces. So all of these that we see here are non-comminuted. There's just two pieces of bone, they fractured in one place. If something's split in more than one place, like this one or this one, this is considered a comminuted fracture. So they're just big umbrella terms, and a lot of these terms that you see here, transverse, oblique, segmental, spiral, green stick, are ways that we can use to describe the type of fracture itself in the angle that it fractured at. You can see transverse is in that transverse plane, oblique is more in an oblique plane, and spiral, it's harder to tell here, but has more of a kind of rotational component. When we talk about positioning terminology, this is extremely important to kind of get down. We talk about the path of the central ray as it enters the X-ray tube and goes through the patient to the imaging receptor, or IR. The central ray is going to appear when we're doing X-rays on the X-ray unit as kind of like a crosshair, so it's where we're kind of targeting where the image is going to go. I kind of want you to think about it like you have a camera and you're taking a picture, what's right in the center? That's going to be the central ray. Some X-rays you'll see are listed as A to P, which is anteroposterior, meaning that the central ray is going to travel through the anterior part of the patient to the posterior part of the patient. And the opposite of that is PA, postero-anterior. So it's going to travel through the back of the patient first and then to the anterior part of the patient. So this is going to tell you, depending on what the doctor orders, what type of positioning that you're going to do to the patient. Are they going to be facing the X-ray unit, or are they going to be facing away from the X-ray unit? So that'll be important, especially this week when we talk about chest imaging. Sometimes things will be listed as axial, meaning that they're going to be more longitudinal in angulation, We'll talk a little bit more about that when we get through to chest imaging. If something's more lateral, we're taking a picture of essentially the profile of that thing. So it's either the left or right side versus just straight on. And then if something's tangential, generally it'll be more of a curved surface. So think of things like the knee. If the knee is bent, it's going to be a little bit more curved. We can also take oblique x-rays. So the central ray will enter somewhere between AP and PA and not exactly lateral, somewhere in between. So if you have an AP oblique, it's going to enter at an anterior surface and exit posterior. And if it's PA, it enters posterior and exits, that should say anterior. So in these cases, we're not exactly looking straight on at the patient. We're not exactly looking lateral. It's somewhere in between, usually at a 45-degree angle. You'll also see a lot of different body positions listed. We'll see some of these this week, like lordotic. But this will give you even more of a clue kind of how the patient's going to be positioned. So if it's upright, generally the patient will be standing. If they're seated, then they're seated. So these are two pretty simple ones. Recumbent is one that you might not have heard of before. Generally they'll be laying down and they could be on their side. Supine is laying on their back. Prone is laying face down. Trendelenburg is supine, but their head is tilted down, therefore their feet are higher than their head. Generally, we'll accomplish this by elevating the feet rather than tilting the head down. Fowler is when the patient is supine and the head is higher than the feet, so it's kind of opposite of Trendelenburg. Sims is a left side recumbent and it's also oblique, so it's a little bit more complicated. Oblique, we've talked about the body's a little bit rotated and kind of at an angle. Decubitus is laying lateral on a dorsal or ventral side, so either anterior or posterior. And then lordotic, the patient is going to lean backward while in an upright position. So they're going to kind of accentuate that curve in their lower back, also known as the lordosis. So in this case, only their shoulders are in contact with the imaging receptor. I know a lot of this is wordy right now, but as we see these in practice, it'll make a lot more sense. We also should get familiar with body movement terminology. So sometimes we'll ask patients to do these, or I'll tell you to do these to the patient because they're not going to know necessarily how to abduct or adduct their arms. But abduct is to move away from the body. Adduct is to bring back toward. Extension is to extend a joint or straighten it out. And flexion is to bend it. All right, so go ahead and move on to the next lecture on the list for this week.